everybody. We are here in this wonderful city, Rio de Janeiro, to start the third SOBEDCAST. I'm Lix Oliveira from Scientific Committee from SOBED, and today we are talking about artificial intelligence with the great professor Roberta Maselli. Roberta, please introduce yourself.
Good morning to everybody from my side. I'm very happy to be here with you. I'm Roberta Maselli from Italy. I work in Milan, and I'm an advanced endoscopy, and I do therapeutic endoscopy mainly, but also I'm involved in the field of AI, as you were mentioning.
Thank you for introduction, but I think all Brazilians know you because you are a great therapeutic endoscopist and diagnostics too, of course. And now the first question is in diagnostic procedures, and what do you expect from AI in diagnostic colonoscopy? We are ready to put in our clinical practice?
The answer to me is yes and no. So we're ready because the system is already on the market, and we have different systems because a lot of companies are working in this field. And for the detection, they are very working well because the sensitivity and the specificity they have in finding lesion is very high. At the same time, there are a lot of questions still on AI. And the first one is, do we really need to find those very small polyps, less than 5 millimeter? Do we really have to remove all of them? Because what we have done till now in the last 50 years in endoscopy is great without any artificial intelligence. So do we really need it? But at the same time, we know from the data and from our patient that there's a high adenoma missing rate. So it means that also the small ones sometimes can be adenoma, and if we leave those adenoma there in time, they can grow up and they can become a bigger lesion. Then sometimes they can cancerize very soon. So this is the reason why AI can help the doctors, because even if we are doing the greatest job possible, we are affected by some external factors all the time. No, we were mentioning also that we can be tired after performing the same procedure over time during the same day, or we can be angry, upset, or whatever, because we are humans. The machine is not, it's totally the contrary. So it's working all the time in the same way, with the same power, so it's not affected at all. Of course, this is the first generation of this machine, so we have to wait a little bit, and then we'll become, because we will make them, they will not become them by themselves for sure, and I hope so, otherwise it will be scary, but we will make them more powerful in the future. But till now, for detection, they are very ready to help us.
Do you expect in the future the same machine can give us with high confidence even the diagnostic, detection, and characterization and quality in colonoscopy?
So for detection is a different topic, and this is why before we were focusing on detection, because characterization is a little bit more difficult. So here the factors, they are a lot and even more, and also for humans it's difficult to make the characterization much more than detection, and this is why we're having some issues in teaching the machine in how to correctly characterize the polyps. Until now we have two big chapters that the machine can characterize, that is the hyperplastic polyps and the adenoma polyps. But inside these two main fields, there's a lot of differences, and also neoplasia starting from LGD, so from low-grade dysplasia till advanced cancer, that will really make the difference. Because what we're trying to do in endoscopy, you know better than me, is to try to judge the histology, and from that judgment we will decide how to remove, and if remove that lesion or not.
Yes.
And also when we are judging an high-grade dysplasia or an intramucosal cancer, then based on the size, location, and a lot of different factors, we will decide how to remove that lesion and block. EMR is the situation is so complex that still, according to me, the machine that we have right now on the market, they are not completely ready. So they are starting to go on that direction, and I'm expecting that in the future they will say with very high accuracy, intramucosal cancer 98%, that means go and remove with ESD and block. Otherwise, high-grade dysplasia, granular homogeneous type, you can remove it also with piecemeal EMR. So this is my hope.
And because when you talk with a young endoscopist, they think the machine will let us train less than the endoscopists have to train now and have to do a good procedure with good bowel preparation and to look all the folds. But what do you think? Do you think this machine, if you have to choose, in training better the endoscopists, the young endoscopists, or to give us the artificial intelligence? What do you decide?
I will go for the first. I mean, if I have to decide, my final answer is both.
Yes.
But at the same time, if I have to decide, I would say the first, because the machine can be the best one ever, but is always depending by some external factors. For example, if if that day is not working because it's a machine,
Yes.
how will you do if you are not trained enough? So still, as I used to say, we have to be as perfect as possible and to be the best colonoscopy possible all the time, because the machine is not a magician and is not ready and is not able to see a polyp if it's not on the screen. So if you don't go over that fold, the machine cannot judge if there's any polyps there. So is judging only what's in the screen. So if the colon is not well prepared, if it's moving too much, if you are not unfolding every single folds, the machine is not helping you. You have to help the machine. You have to work together.
Yeah.
In this way.
And I totally agree. And because I think for detection, the machine is ready now. But how do you say? We don't know the clinical significance to find a lot of small adenomas and less than 5 millimeters. But I think what do you think the artificial intelligence? Maybe we can say she's a second expert in the room, and the second expert don't hurt your ego, because if you don't find and the machine find, it's okay. It's better it's better for the patient.
Yeah, I like what you said. At the beginning, when they gave to me, I was really fighting with the machine because my ego,
Me too.
was breaking. And it was like a real fight. I saw the polyps before the machine. Yes, I'm better, and I'm recognizing that this is adenoma. I'm saying that this is plastic. It's not true like this, but finally, as we should use it after our judgment and after our knowledge. I mean. Mainly for characterization, I used to in this way, and I forced and I suggest, let me say, my fellow to do in this way, to try to understand by their own, applying all the classification they know, the crumb endoscopy, and all the knowledge they have to judge that lesion, and then just at the end, they would just push the button and they will ask to the machine, what is it to you? Just to have a confirmation, because the other aspect is that till now, it's not legally recognized, the artificial intelligence. So the final judgment and the final decision is made by us, by doctors. So it's better that they start from the beginning to understand by themselves. And then if they have a machine, because maybe in the future they will work in a place where they don't have the artificial intelligence, how will they handle that procedure? They will have a confirmation to a second expert, as you were saying. I really like it.
Yes, me too. And what can we expect from the artificial intelligence in the quality of colonoscopy? What do you think? Do you think it's get better, or the quality is only for us, for the endoscopist?
Yeah, this is a new chapter. So they started with detection and characterization, but then they are moving to something more, also reporting, And I like this concept because we cannot be sure 100% that we've done everything, although we think that. And this is the reason why we have some quality measurement text, for example, the withdrawal time that should be not less than 6 minutes, and all these different things, or the Boston scale for the bowel prep. Try to summarize and to have a level of quality. So if the machine helping in detection and characterization could also help us in reaching all this quality level, I think that would be the best all over the world, because in every single country we have very differences in high volume centers, academic centers with all the possible technologies, and standard centers where they are still working with different and old scopes. So if the machine can, let me say, democratize the quality, it would be the best for our patients.
And now let's move a little for therapeutic colonoscopy. What artificial intelligence can help us in therapeutic procedures? Is it possible?
What we have till now is nothing on the market. So we are working on this, and mainly we are following the same pathway they are doing with artificial intelligence in surgery. So it means in a real time, the machine right now what they are working on is to let you understand which tissue you are facing, and in particular, for example, ESD, you will be able to understand which one is the muscle, which is the submucosa, and also the vessels and the anatomy of vessels. So with this you will decide which tissue you have to coagulate, which one you have to cut. But this is just the first step, and I think that also with the advent of the robotic endoscopy, that finally I hope that will give to all of us the triangulation that we don't have. So therapeutic endoscopy is so difficult because we are doing everything with just one hand, usually the right. And I used to say that it's like you want to cut a steak just with the needle without the fork.
Yes.
So your second hand is disappearing, and you have only one. You have no traction. Something that is, while you are cutting, is moving.
Yes.
And it's bleeding. It seems to me that the worst scenario possible, like we are operating in the air. And this is why we try to have some fixed position to have stability and triangulation. So once we reach that point, also having two arms, will become flexible surgeons. And at that time, artificial intelligence will have a second step in therapeutic endoscopy, because it's what is happening in surgery. So we are following parallel the same pathway.
Then you tell us that if you put together robotic and artificial intelligence, maybe we don't need too much expertise to do the same procedure that we do today, with very, very difficult and sometimes very long procedures.
I don't know, because in the other hand, challenging procedures and challenging situation, challenging you.
Yes.
So push you to give the best and to do the best all the time. When something becomes too easy, your alert and your level of quality can go a little bit down. So there are different point of view. I don't have any answer. I hope it will help us, but at the same time, it will push us to do our best all the time.
Do you expect in I don't know how many years, they don't, the artificial intelligence will lead us that they don't need endoscopists to do the procedure? Do you expect this?
Even here, the answer is, I hope no. I don't know. I don't think so. There are different steps from just human doing things to complete robotic and machine doing without humans in a standard, pathway. But let me say they are still number 215, and I hope they will stay maximum at level 3, not reaching 5, because 5 means that the machine won't need all of us. And I think it's not the case, but the future is bright, but
Yeah.
it's unknown.
And you can think about the responsibility of if the machine says no, leave in situ this polyp,
Yeah.
and 3 years later the patient comes with advanced cancer, and who is the responsible? Not the machine.
Yeah, exactly. From this legal point of view, it's crucial to understand the role of the artificial intelligence. And also the other fact is that do we have to write down on the report that we are using it? Do we have to ask for a specific consent from the patient to use it? Do we have to ask a specific reimbursement for AI? So there's a lot of questions still ongoing because it's a new era. And we are expecting that all of us all over the world, we use the artificial intelligence because it's simple. It's just push a button, nothing more than this. It's not changing the practical endoscopy to patient, but it's changing the management and how we'll decide about the lesion we will find. So there's still a lot of question. And I think that we have to work all together to try to make the right answer.
And do you think they will help us the another in the Fujifilm that there's you can measure the size of the polyp? Do you think it's so important? We work until now
Without
without I know it's maybe what I think it's for me 5 millimeters, for you 6, 7, but do you really think this is important to have, because it's too expensive?
Yeah, you're completely right, but everything we've done till now without all of this machine, we did it.
Yeah.
But if we can become better and faster and safer and better in general with the machine, why not? So the question is that I was really impressed that we made a sort of review from different experts in different countries in Europe, and they show different polyps or lesions, just asking what's the size according to you, and it's unbelievable, but all of us we disagree.
Yeah.
Even if we have the comparison of a snare open over there, the snare are completely different all the time, even the same brand snare, because they are depending from the humidity or whatever. So they can open in a very small, little different shape. That means different size. So even the same brand snare with the same size open nearby will make you a different judgment. And my first question was, who cares? There's no reason to understand if that polyp is 19 millimeter or 20 millimeter. It's around 20, something like this. But the fact is that you know that this doesn't make any difference. But to judge a lesion 10 millimeter or 25 millimeter or 20 or 50 millimeter is completely different, because by guidelines, if you are not a very high volume center, you should send that lesion to a high volume center specialized in MR and ESD. And if I saw the picture, if I don't have the artificial intelligence that really estimate and judge also the size, sometimes the patient comes without any images in the report. So if that colleague said 25 millimeter for ESD non-granular type, I have to weigh. I will repeat endoscopy. That means bowel prep, one more endoscopy that is an invasive procedure, one more sedation, just to make again the diagnosis, and that one will serve me to plan and schedule the procedure with the right time slot and with the right devices. Or I can go directly and I would say to the patient, I don't know what will I do if it's EMR, ESD, and for a long time, but I cannot say that the doctor was not able or didn't have the devices to do its best. Yeah. So to come to your question, I know that everything we have now, they are expensive because they are adding something more in basic procedure where the reimbursement is very low, but we need to estimate the size because the guidelines are based on the size.
Unfortunately, I have to finish, but I will ask the more two questions. If you have to leave a message for young endoscopists about the future of AI, what should it be? And the second, unfortunately, we have to close it then, Roberta Maselli. if someone listen to this podcast 20 years from now, they will be lost that about what we're talking, or call us visionaries?
Wow, thank you for this question. So, to young people, I would say you're lucky because you are in a new era and you are learning in a new era. But at the same time, don't lose the what all the other people before us and we are doing. So learn a lot and work hard from the basic and the basis, and then use all the technology you will have. Maybe because you grow up with internet and technology, you will be visionary, and you young people will have new ideas in how to use the technology in our field, and I'm looking forward for that time. And about the second question, I think they will laugh at us because we are the artificial intelligence we are using in endoscopy is really rudimental compared to all the other artificial intelligence in the world. The facial recognition at the airport, or the footprint. So that one, they are very complex. In endoscopy, it's very simple what we are doing with the machine, and this is why I really push the young generation to do something new and to apply the real machine to the medical field and then also to endoscopy.
Roberta Maselli, thank you so much for sharing your knowledge with us and for your time. And I hope another podcast we can have with you because it's very nice. Thank you.
Thank you all.